This conference will now be recorded.
Okay, clear, fine. So I'm starting now. So welcome to Prolapse class. So first of all, see, I'll be just explaining you what are the parts that are important in prolapse and from where the questions come. Okay. So prolapse, this question is very common. What is the lifetime risk or what is the lifetime incidence of it? Okay, this question is a recall and answer is 11%. And this slide I have taken from strategy, and one question came in 2016 exam, lifetime risk for prolapse surgery, and there were many choices, but from them 11% was the answer I take. But you have to remember this percentage, 11 to 19 percentage. According to that, you can answer your question. So this is a recall question. Then what are the risk factor? I'll be just giving you some briefs, and because sometimes this question they will give you a scenario, and they would ask you what are the risk factor for prolapse, or they can ask you what is the modifiable factor and what is the unmodifiable factor. So these three types of question usually come from the risk factor. Some important percentages also I have added in this. So age, we already know, is a risk factor, and pregnancy. So now these two percentages are important. We already know prolapse happens because of the trauma that happens to the pelvic floor because of the pregnancy changes and childbirth. So incidence of prolapse in paras is 50%. Incidence of prolapse in nulliparous is 2%. So this parity and vaginal birth, these two are the risk factor. Nothing new about it, you already know. Just remember these percentages: 50% in paras and 2% in nulliparous. Then ethnic origin, sometime you will find question from this also. Ethnic origin. So what they say about the ethnic origin, it is common in Hispanic American women and lowest in African American women. Difficult to remember, just remember where it is highest. That will help you. It is Hispanic American women. Then smoking, we already know, it puts strain on the pelvic floor muscles. Obesity does the same thing. And yeah, the menopause is again a risk factor because of the lack of estrogen support during the menopause. So these are the risk factors. So it is important to know, to answer the question gives you find out the risk factors. Okay, occupation is important. We already know this: prolonged standing, heavy weight lifting, doing lots of manual work. All of this are puts the pelvic floor muscle at stress. So these are related to increased chances of prolapse. But on the other side, what the research has shown, housewife are has got prolapse more than a working woman. And sometime you will find the SBA. There are some SBA where the correct answer we are not able to find. Answer is given by just exclusion, and this line may help you. Therefore, I have put it here, and this is from strategy. Then constipation, COPD. These are two factors that will again cause the weakening of pelvic floor muscle because of the stress. So these are the risk factors that are important to remember, because we'll be having question with this also. Then family history and genetic risk, you already know some genetic syndromes are there. What are these? Are connective tissue disorder. These are Ehlers-Danlos syndrome and the Marfan syndrome. They have got a high incidence of organ prolapse. Okay, so this you know already, nothing new about it. Then so that's all about the risk factor. So it is important to know. Just to sum up, nulliparous slight percentages what we have read till now. Lifetime risk of prolapse is 11 to 19%. Incidence of prolapse in nulliparous is 2%. Incidence of prolapse in multiparous is 50%. Till now, we have learned only three percentages. Question also come from the level of support. So there are three levels of support: 1, 2, and 3. What is the first level? That is a suspension. This is the main support, because cardinal ligament, that is the McEnroe's ligament, and uterosacral ligament. So these are the sort of important support, and we calling it as a suspension, because whenever we are doing hysterectomies, suspension of these two ligaments are done. Okay. Then the second is the attachment. These are the facial supports. These are arcus tendinous and arcus tendinous fascia, and the fascia over pubococcygeus and iliococcygeus muscles. Okay. And third is lower one, that is the pelvic floor, urogenital diaphragm, and the perineal body. So you have to remember these three levels of support, and in the same wording. Why? Because if the SBA comes, so you have to know that level 1 suspension is UC, that is uterosacral and cardinal ligaments. Level 2 is attachment. Attachment, you'll be able to find out this fascia over these two muscles. Just remember this PC and IC. Okay, so this part is important. And third one, you will be knowing. So just remember this urogenital diaphragm and the perineal body. You have to know the right terminology. Why? Because otherwise SBA you will be confusing. So this part is important, though it is not important to learn the name of the scientist, but it is De Lense. If you wish to remember, you can. So now, these days, prolapse classification has changed. Now the classification is done according to the compartment. So compartment is anterior compartment. And what are the prolapse that comes in anterior compartment? It will be cystocele, urethrocoele, cystourethrocoele. And differential diagnosis for this compartment will be the vaginal cyst, abscess, and urinary diverticulum, because sometimes they will confuse you with this. So this was important to know. So this is anterior compartment. Okay, so this is the anterior compartment. You have to remember this. Previously, this compartment classification was not there, but these days it is there, and we have to just remember this, or we have to do our questions according to these compartments. Apical compartment, this is also the middle compartment or apical compartment. It consists of the vaginal apex, and if the uterus is prolapsed, okay, so see, if the uterus is prolapsed, then it is apical middle compartment or the apical compartment. Okay, so it is important to remember, because they may give you SBA. They could give you SPA. So uterovaginal prolapse belongs to which compartment? So your answer will be this. So therefore, this knowledge is important. Now this is the posterior compartment. You already know what the posterior compartment may have. It can have a cystocele and enterocele. So this is the posterior compartment. Okay. Now a number of questions. Okay, Vishnupriya has joined. Okay, Vishnupriya. So a number of questions will come from this few slides, and very frankly speaking, you have to remember this by heart, because it is important for part 2 and part 3 people both. For part 2, they have to remember it by everything, whatever they have written, because otherwise you will get confused in SBAs. So this is POPQ, and this is given classic quantification system. So therefore we have got compartments, because the system of prolapse classification has changed, and it is POPQ, pelvic organ prolapse quantification. Okay, so usually you may get SPAs, how many points to measured in vagina. So answer will be 6. Again, with what you are taking as a reference. So reference is hymen. Okay, so every line is full of SBA. It is respect to hymen. Again, this line forms a question. So points, those are above hymen. So if this is the hymen, if the points are above it, that means these were negative numbers. Or you can remember point above are negative, or point which is inside the vagina or inside the woman's body are the negative numbers. Fine. Then point, those are below hymen. Okay, I will explain you. It will come in future slides also, coming slides. So point that are below the hymen, this will be positive points. So now again, normally if the woman has got no prolapse, you will not get even all points that you are measuring in vagina will be negative numbers. So if the woman has prolapse, you will find that the number has come positive. Okay, then another question that can come, all of the points are measured with Valsalva, maximum Valsalva. That means whole prolapse is out. Okay, only there is single point that is measured after reduction of prolapse, and that is TVL. Fine. So these are the points. So there are 2 points. They are on the anterior wall. So this is AA and BA. So this very confusing, but you remember from small a. If your point carries small a, that small a means for anterior wall, and uh, P, small p, means for posterior wall, C for cervix, D for pouch of Douglas, and this GH is genital hiatus, PB is perineal body, and this is TVL. TVL is vaginal length. So all are different point. There is no confusion. Confusion will occur here. Just remember this by a dictum. Small a belongs to anterior wall. It is the small number that will give you the identification of the wall. So please remember this, because I myself do have done so many confusion with these numbers. Okay, just remember this. And if the patient is having no prolapse, then this A and A, they will point on the anterior wall. It will correspond to the point on posterior wall. That means these points will be same. This is on anterior wall and this is on the posterior wall. And also, if the patient has no prolapse, point on the anterior wall this, and point on the posterior wall this. This both will be at the same level, or what we can say, these are the mirror images of each other, or they will correspond each other if there is no prolapse. Okay, so the main confusion occurs in these 2 points. It is important to remember this. Now, this part again is very, very important, because you will get a number of questions from here. So what is AA? A is small a, that means anterior vaginal wall. So AA is the point 3 centimeter proximal to hymen. So now see, this is hymen. Okay, this is vagina. This is hymen. A point on A for anterior wall. So this is anterior wall. So a point on the anterior wall, 3 centimeter proximal to hymen is AA. Okay, so this is AA. And if you remember, if you are able to understand this, then you'll be able to do all questions very well. And they have got a range -3 to +3. -3, that means it is at its normal place. +3, it is out from vagina 3 centimeters. Okay, and same point. Now coming to BA, the BA is the point, small a belongs to anterior vaginal wall. So this will be a point on the anterior vaginal wall, but it is on the most distal point. So if there has been no prolapse, so voice not audible. Now it is okay, clear? Vishnu Priya, are you able to hear me? I have come close to it. Is it okay? Okay, Rajni, clear. Fine. So, where I was? Okay, is it clear? Fine. Okay, so what is BA? A belongs to anterior wall. So the BA will be on the anterior vaginal wall, and this B point, this is the most distal point. So most distal point is this one. Okay, so here you will get this point. This is the most distal point. This you will get BA. Fine. So this is the most distal point on the remaining anterior vaginal wall. It is AA and BA is clear to all people or not? Okay, good. So now coming to these points. So this is P. Small p belongs to posterior vaginal wall. AP. So AP will be a point on the posterior vaginal wall which is 3 centimeter proximal. So this is hymen, 3 centimeter proximal to hymen. So this will be this point. So this is AP, and as I already said that this big letters will be mirror image of each other. Okay, so these are two big letters, they will be mirror image if there is no prolapse. And BP, means for posterior vaginal wall. So this is posterior vaginal wall. So this will be the most distal part of posterior vaginal wall. P for posterior vaginal wall. So this is the most distal point on the posterior vaginal wall. So this way. So if there is no prolapse, then BA and BP, that means all big letter will be mirror image of each other. They will correspond to each other. Okay. So it is important to remember these 4 points because rest all are easy. So just dictum, all small letter depicts wall of vagina, and big letter, if there is no prolapse, there are mirror image. Just if you remember this, then your job life will be easy. So C, what is C? C for cervix. It is the most distal point of C or vaginal cuff scar if hysterectomy has been done. Okay. So this is the most distal point of C, cervix. Small letter for, small letter for vaginal wall, big letter, these are mirror images of each other. D will be pouch of Douglas. You will get an SPA where they will say hysterectomy has been done. So what point will not be there? So answer will be D, because if the hysterectomy is already been there, so there will be no POD. Then GH, this will be genital hiatus. It is measured from external urethral meatus to posterior midline hymen. So this one, and from this point to the mid anal point, this will be your this will be perineal body. And if the prolapse has been if prolapse has been reduced, then they will measure the vaginal length. So this will be TVL or total vaginal length. So this will be your TV, this will be the patient's TVL. So this is the explanation, and you have to know this by heart because you will get question from this part. Am I clear up till now? Okay. Now it is also very important because sometimes they will give you some numbers or they will give you some grid. I will tell you that grid also, and you have to do the staging. Or sometime you will they will tell you what will be the treatment. So first from the grid you have to find out what is the stage. Then according to the stage you have to do the treatment of the patient. So stage zero, that means normal uterus. All points are -3. Okay, and the C or D, this will be less than TVL -2. Stage 1, when these criteria are not met, prolapse is there, but the leading is less than -1. And this why -1 we are measuring in reference to hymen. That I have already told you. A stage 2 leading age is more than -1, but less than equal to plus. So that means here it is less than -1. But now in stage 2, it has come out TVL -2. TVL is total vaginal length, and -2 you have to do calculation, Aisha. And I will explain you this in the question also again. Okay. So this staging you have to learn. So this leading age is less than -1. That means it has more than -1. Sorry, less than -1 was stage 1. If it is more than -1, but it has more come out. Plus means the it has come out of the vagina. That means plus, if it is +1 prolapse, so you can remember, you just can imagine in your head that prolapse is out from the vaginal hiatus, and it will be like 1 centimeter. So from the vagina, 1 centimeter prolapse will be out. Okay, just remember like that. But you have to remember this for SBS. I can't help it. Stage 3, if it is more than this but less than TVL -2. And leading the stage 4 is leading edge is more than TVL -2. Now I will explain this again. This part you have to remember, but when we are doing questions, I will tell you the application of this. Okay, so that time this will be more clear. Okay, so this is stage 0, uterus in the its position. This is stage 1. Now you can find out that it is only slightly out. So it stage no, sorry, so this is vagina, and this is uterus is prolapsed, but it is still inside the vagina because it is -1. -1 means will be inside the vagina. Okay, now stage 2, it will be outside but +1. So it is outside. This is vagina. So it is outside the vagina, but slightly outside. You can say 1 centimeter. Okay, and here in stage 3 it is outside, but it will be more than +1. Okay, and in stage 4 it is complete eversion, whole of the uterus will be out. That means leading edge will be more than TVL -2. I will explain it again in the question. And I don't know whether I don't think so that this grade is given in part 2 exams, but it is important to remember this grade because they may give it. So above is anterior thing. So anterior wall will be upstairs. So this is anterior wall point, this is anterior wall point, and the, this C you have to remember. This is will be GH, PB, perennial body, and TVL. And last grid, part of the grid belongs to posterior wall. So both posterior wall point and the D. No, this just see this because you need not to remember that this by heart. You have to just know this. What is this grid? Because in your question answer, this grid will come. Now I would just like to explain you people. Now any one of you can tell me this is prolapse. Okay, so any one of you can tell me this is which prolapse? Just do some guesswork. At least one person should answer. Very good, excellent. It is posterior compartment. So now you can see people, I said plus means it is outside. This is, they are depicting hymen by this. So plus means outside. Now see here, this AP and BP. P belongs to posterior wall. Now you can see +2, +5. So this, you are dealing with posterior wall prolapse. And here on anterior wall, if it is -3, that is normal. So see here, it is minus. That means the anterior and posterior vagina, anterior wall, both points are in. So there is no cystoscopy. You can see it is inside. Okay, only posterior wall prolapse is there. Now again one thing. So now people, Aisha was asking this. So now this is TVL. TVL is it. If you do -2 from here, then Answer, then you will get 6. Okay, so if your leading edge is less than 6, then then it will be stage 3 prolapse. So you can say here TVL minus 2 is 6, and most leading part of prolapse is plus 5. That means it is less than 6. So if it is less than 6, then it will be here. Now TVL minus 2 was 6, and your prolapse is less than 6. So it will be this thing, posterior compartment or rectocele, stage 3. Aisha, is it clear now? Yes, it is
Yeah,
stage.
clear, Dr. Priyata. Now I understand. Yes, very clear.
Okay.
Priyata, it is clear.
Yeah, okay, thank you. So I will be giving you more questions. I didn't wrote any answer. So someone tell me, what is this prolapse?
This is anterior compartment prolapse,
Yes, yes,
cystoscopy.
This
yes. This is
this is anterior
anterior.
wall prolapse.
Yes,
Anterior wall
this
prolapse.
yes, this is anterior wall prolapse, and this is cystoscele. Now this TVL,
Cystoscopy.
yeah. So TVL here is 6, and if you do minus 2, it will come as 4.
4.
Okay, and so and your
It is less
prolapse is
than the leading point.
yeah. So
TVL minus 2 is less than the leading point.
TVL minus, so this is TVL, and minus 2 will be
Yes,
4. Minus 2 will be
4.
4. Yeah.
But BA
So
is 6. It is
so
less
it
than
is 4
leading
stages.
point.
So this is stage 4.
Stage
Yes,
4.
right. It is stage 4. Very good.
Stage 4.
Yeah, yeah, excellent. Now you come to this
Dr.
again same.
Priyata, can you please explain me? This is 6. 6 minus 2 is 4. So
Yes,
it is
and prolapse is 6. So
6. Okay.
your prolapse,
Okay. Yeah. Stage
it
4.
is
Yeah,
more than
I
2
understand.
minus 2. Yeah, okay.
Yes.
Yeah. And so now this is which prolapse?
Posterior wall prolapse.
I think this
Posterior
is,
wall.
yeah, this is, we have done this. Not this, again this picture. Now this is which prolapse?
This is again
This
posterior wall
posterior.
prolapse.
Posterior wall.
Posterior wall prolapse.
Now people learned well. Now this is the so now these are the questions. Okay.
Okay.
Now somebody, please all of you mute yourself. Okay. Now these are the options for you, and this is now I have given this you as a question. You please read this question, then I will show you the options again. You have to give me answer. So if you have read the question, then I will show you options again.
Anterior wall and 4°.
Anterior wall prolapse.
Stage 4.
Anterior wall prolapse. This is anterior wall prolapse.
Find out the option from here.
E. Answer is
Priyata,
E.
can you show the question again? Can you show the question again? TVL minus 2. 4. Is it stage 4? Anterior wall prolapse? Can you show the question again? Sorry.
This is question.
Sorry, option sir. E. Stage 4. Anterior vaginal wall prolapse. Cystoscopy.
They're saying it's 3. Let us find out why it is 3.
Yes.
Yeah, so this is 6. 6 minus 2 will be 4. And it is more than 4. It is more than 4.
Okay. TVL minus 2 is 4. Leading point is more than 4.
Yes. More than 4, TVL minus 2 more than 4 is stage 4. It should be stage 4. So if leading age is more than TVL minus 2 is stage 4. So I will give answer in stage 4.
Stage 4, right? Yes. Okay.
Yes. I will give
Okay.
stage 4. So this is the question again.
Is this anterior vaginal wall prolapse?
How come? See here, this is plus and this is plus, but see here also.
Yes, yes, yes. It is even apical prolapse
So cervical
with
descent will
uterine
also
descent. Cervical descent is also there. Yes.
So it should be anterior prolapse with cervical descent.
Stage 3 cervical descent J.
So what is the answer? So yeah, you are right. It is J.
J. J. J.
Now this is the question.
This is posterior vaginal wall prolapse
Yes, this is posterior.
with the stage 3.
Yes, it's more than +1. So it is more than +1
Because
only.
TVL is 8. 8. TVL is 8. So minus 2 is 6. That is more than plus 5.
Yeah, I will put it stage 4, but they have put it stage 3. Because they have shown the stage here. TVL minus 2. TVL is 8. And minus 2 it
Yes,
becomes 6.
yes.
And leading edge is
6.
6. So
Leading edge is plus 5.
okay. Yeah,
Leading edge is +5.
so it is less than TVL. So it has to
Yeah,
be 3.
Leading edge is less than
3,
6.
3.
So stage 3,
Yeah,
no? Stage
yeah,
3 posterior prolapse.
yeah. So it is also right. So we have done 3
Okay.
questions. And yeah.
Yes.
So this was a little bit of brainstorming. So is it clear? PopQ is clear. Should I move ahead?
Yes, Priyata. Thank you very much. First time I understood the PopQ very clearly.
Yeah, really, I
Thank you.
understood for the first time this
Thank you
PopQ.
so much, Priyata. Thank you so much.
You're welcome. So
Thank
now
you.
all of you now mute yourself because so much voices are there. When we will do question, then you can again come again back. Fine. So because this new guideline has come, nice guideline has come for prolapse. So now whatever the question will come, answer will come from that guideline. So I have just put the sum up of all important points. So whenever that can come as a question, fine. So if first of all, if the prolapse is there, the patient will come in the primary care. So people, whenever it is a woman is coming with prolapse, you have to take 3 compartment history. You have to take about urine problems, bowel problems, and sexual problems. So these 3 are important. And examination, when you will do examination, if there is pelvic mass or other pathology. You are doing prolapse grading, you have to do staging, you have to do, but also you have to rule out whether if it is there any associated pelvic mass is there or any pathology is there. Then now this so initial treatment will be done in the primary care. Primary care is a GP care, okay, GP surgery. So initial part will be done here. Then some of the patient directly will require referral to secondary care. So why? If there had secondary care, which patient will go to secondary care if they have got unrelated condition but they have incidental finding of prolapse. So now the patient has come for some other condition, okay, but they have now you saw the patient and you find that there have GP find that there had been incidental finding of prolapse. In that situation, the patient has to be referred, because there could be possibility that the reason for which the patient has come may be somehow related to vaginal prolapse. Because sometimes you will get question, because okay, let me come here, because sometimes the question will come and answer will come referral to secondary care. So referral to secondary care will be done for unrelated condition, but the patient has come with the problem of the problem of incidental symptoms of prolapse, or you have got the incidental finding of prolapse. In that situation, patient has to be referred to an expertise. This it is important. Then when the specialist, now voice is clear? Now voice is clear? Yeah, okay. So now when the woman has already there in the secondary care, then what they will be doing? They will be doing their examination. They will be doing assessment, and they will be doing record. They will record it, the presence and degree of prolapse, and how they will be doing. They will be doing in POPQ quantification system. So they will be doing first part this. Second part, they have to see strength of pelvic floor muscles, because whether the patient is early patient stage prolapse patient is for conservative management, or whether the patient will require, what type of support will be required in surgery. So it is important to assess her pelvic floor muscle strength, and also if it is an old woman or the menopausal and vaginal atrophy. So these three things will be assessed by the specialist or the clinician in the hospital. So you may get an SPA. You will in that question they will give you this, and in second B part they can give these two, and in C part they can do these three things. Like the doctor will assess for POPQ, pelvic floor muscle strength, and vaginal atrophy. So your answer will be all of these. So it is important to know in that situation, and also they will see whether they will rule out if there is any pelvic mass or any other pathology is there. So this examination will be done by the specialist when the referral has been made from the primary care or from the GP surgery. Now what they are saying, so prolapse, you already people you know the prolapse. Prolapse is a clinical diagnosis. So routine investigations are usually not done. Any kind of imaging, like they will not do any USG, or they will not do any USG, or they will not consider any other imaging, MRI or anything routinely. So routinely it will not be done. Fine. Sometime what happens, so you will get a question from here. So any investigation that is required for documentation of prolapse, your answer will be no. No investigation is required. Another part, they will say that another question that can come. So patient has come with the symptoms of prolapse, but on physical examination you are not able to find it. So what you will do? So your answer will come. You will consider repeat examination, physical examination in different position, standing, squatting at a different time. So this part is important, because this can one SB can come from here. So if the prolapse are not obvious or you're not able to find, then call the woman next time, repeat examination in standing, squatting or position or at a different time. So this is important to remember, because you will find another question like in what positions examination of prolapse can be done. Okay, so your answer will come from here. It is important because, you know, in SBA where is small single words becomes important. Now sometime, so if there had been no issues, no, then you won't be doing an investigation, but there are some indication where you will perform offer this woman investigation. So what are the symptoms? Now if the patient has got bothersome urinary symptom, okay, so in that situation you have to order some investigation. Second, that is because now she's having some anterior part symptom or urinary symptom that are not related to prolapse. Second, if the patient has some posterior compartment problem like obstructed defecation or fecal incontinence, you have to do some investigation for this woman. If the patient has got pain, usually prolapse patient, they complain of you of something coming down or the dragging sensation, but if the pain is associated, that means we are missing on something. We need that is a indication for investigation. Apart from this, if you are finding some, so these are from the complaints. And now if you have examined the woman and her symptoms, what she is saying and what you have found, so there is mismatch. That means there could be possibility you might be missing on something. So if there had been symptoms and findings mismatch, you have to investigate this woman. You can get any EMQ and SBA from here. So these are the investigations, indications for the investigations. Urinary compartment symptom, posterior compartment symptoms, any associated pain, or if there had been any mismatch of symptoms in the examination finding, you have to consider for investigation. So these are the, you may get question from this part of the guideline. Again, now this is after that you can uh, get questions about the treatment. So these are the, so first will be the conservative, or what we say is the modification of the lifestyle. So if the BMI is less than 30, you have to say patient please lose weight. So this BMI 30 you have to remember, though you remember this from the infertility guideline also. Every time they say the weight has to be BMI 30, so you can get an SBA from here. Then this part you already know, preventing COPD or preventing constipation. So this will also come in preventing or treating constipation, and also doing prevention treatment for COPD, because these all this will cause chronic cough, pressure on the pelvic floor, and cause a worsening of this prolapse. So this is important. So constipation can be prevented and treated, but COPD can only be treated. It cannot be prevented because it is already there. So the important part of this slide is they have to lose weight if a BMI is more than 30. Now whenever you are examining women, so and if you they already said that you have to look for vaginal atrophy. So if vaginal atrophy, then only for the treatment of prolapse you will be offering vaginal estrogen. This is easy thing, you already know this. Now this is important. So if there are certain estrogen releasing rings are there. Now if the patient is have got cognition problem, if the patient has got physical impairment, so like she won't be able to use this regular creams or vaginal estrogen pastry, then there is option of vaginal ring, sorry, this vaginal estrogen releasing ring there. So now the SPA will come for here. This patient has got she is is an old woman living, nobody took care, living in a care home, or she can't move, or she can't remember, and she has got vaginal atrophy. In that situation, previously answer was vaginal estrogen. Now the answer has changed from vaginal estrogen to estrogen releasing rings. So this part is changed in the guideline. Please put it in your head that you have to answer, put an answer for estrogen releasing ring if the patient with cognitive and physical impairment is there with atrophy. Now, again, what type of question? So if they have given you any question and the staging comes as stage 1 or 2, we have just done staging. So 1 or 2 people you will allow. So first line of treatment for them will be this is supervised pelvic floor muscle training. This we have done in incontinence class also. Okay, so what is the difference in the incontinence exercises and prolapse exercise? In prolapse, it is 16 weeks, and in incontinence, it is 12 weeks before any woman is able to see any effect of the exercise. She has to do it for 16 weeks. So please remember, here is the catch. I'm repeating it again. In stress urinary incontinence, it was 12 weeks. In prolapse it is 16 weeks. So here the question can come, and exercise will be the treatment for stage 2 and 3. These are the two SBAs from here. Now what could be the another line of treatment? It is the pessary, and pessary question you people will get less, but it is a very hot and favorite station for part 3. So we teach pessary details in part 3. For you, what is important? So pessary will be for a symptomatic patient, you can give a pessary. And if the woman has, they have got a special pessary clinic also. So the patient can be referred to pessary clinic. But if that facility is not available in the area where you are seeing the patient, you can refer to the Urogyne service also. So you can get question from here. So now the woman has chosen pessary, but it is not available where at the GP surgery. So the patient should be referred here. Okay, another this part is very important. Only this much is important for part 2 people. Satisfaction in prolapse with the pessary, it is 92%. Satisfaction in urinary symptom will be 50%. Now, please remember these percentages. You will get question from here, and this is from one of the talks. I don't remember right now from where talk I have put it here, but I think it is 2016 Prolapse talk, where our name of the talk is whether the hysterectomy is necessary for prolapse. This was I think the name, and it is in 2016 from where I have taken this line. Remember these two percentages. Satisfaction rate 92%, satisfaction in urinary symptom is 50%. I just find these two lines important, therefore I have put it here. Remember them, you may get any question. Then before the pessary treatment, if the patient has atrophy, please, your answer will be topical estrogen first. Then whatever, so it is usually done with a hit and trial manner. So you have to explain this to the patient. No, we won't be able to put a pessary at a single attempt. We have to try many pessaries, but like 2-3 times we have to try before the correct size has to be find out. So she would require more than one fitting, and this part. So the sexual intercourse. So there are I don't know whether it is important for part 2, but I will tell you there are certain pessaries are there in which sex is possible, and there are certain pessary where the sex is not possible. So this is a ring pessary. I'm not giving you complete knowledge about it because I don't think it is important for part 2. So this is ring pessary. So if the question says she's looking for, she's sexually active, your answer will be ring pessary. But if the question says, so this is, now you can see this pessary. If your question says that she's not sexually active, then your answer can come from this. So this is Gellhorn pessary. So just remember two things with Gellhorn pessary. This is Gellhorn. Another type of pessary is shelf pessary. There are two types of pessary, Gellhorn and shelf. Vaginal intercourse is not possible. Now you can imagine, make it out. This knob will be lying in vagina, so intercourse will not be possible. Okay, just with a pictorial presentation, maybe it will fit directly into your head. So if the patient is not sexually active and pessary, they have given Gellhorn or they have given shelf pessary, your answer will be that. And if she is active, then answer will be ring. And this part I have already told you, and please remember it. You may get an SPA from here. This part also I have explained you. So they have got a pastry clinic. So again, a question will come from here. Appointment, once the pastry is fit, how long, after how many months the patient has to come if she is doing well? Answer will be every 6 months, and there is a pastry clinic. So she has to see a pastry clinic every 6 months because there could be associated complications. So you have to rule out that, she would require regular visit at 6 monthly interval to the pastry clinic. So this is all about lifestyle management. So I have already explained you. So first for atrophy it is estrogen. For another woman, the cognitive and physical behavior, it will be vaginal estrogen releasing ring. Pelvic floor muscle exercise will be for stage 1, stage 2, 16 weeks. She had to do it for 16 weeks. Pastry, about the pastry I have already explained you. Satisfaction rate will be 95%. Urine symptom satisfaction will be 50%. And they have to see pastry clinic every 6 months. So these are the few questions you may get from pastry. Now, after lifestyle management, there is no medical management for prolapse. So next line will be surgical management. So surgical management will be offered if the lifestyle management hasn't worked, or if they're not happy with the non-surgical. So you have to offer surgical treatment. So whenever the surgical treatment is offered, you have to explain so many things. So because there are a number of surgery, what are the surgery are there, and you have to explain them about the recurrence. I don't know about part, I never found this in a part 2 books, but see, you have to remember this. Recurrent prolapse recurrence rate is 30%. This is from the prolapse leaflet. So please remember it. You need not to remember, read leaflet at part 2 level. The recurrence of prolapse after surgery is 30%. Please remember this number. Then you have to explain sometime what will happen when the patient is taken for the surgery, and sometime the prolapse will become more evident, or some the prolapse that are not there in clinic finding, it will appear because of the relaxation in the intraoperative period. So whenever you are taking any consent, you have to explain this to this patient, that if there had been further, they found some prolapse that has become evident during intraoperative prolapse assessment, then their treatment may change. So this part is important. Sometime in ethical or consent issues you may find this. So you have to explain intraoperative prolapse assessment and change in the management accordingly whenever you are taking consent in the pre-admission or pre-anesthetic checkup clinic. Now again, about the incontinence, what they are saying, what you have to explain about incontinence. What happens, because if the prolapse is there, then it causes kinking of urethra. You already know, if there is a prolapse, some part of bladder will drag in cystoscopy, and that urethral kinking will be there. So because of this urethral kinking, if the patient previously has stress incontinence, so she will feel a little bit like improved of the symptom. So once the surgery for prolapse has been done, that kinking will go away. Okay, then suddenly her stress incontinence or the incontinence will become, uh, she will be noticing it again. Okay, so now what they are saying, uh, because of this problem, whenever you are offering surgery for prolapse, and when the assessment you have done for prolapse, and you are not, you don't and you don't find that patient has got incontinence, you need not to offer surgery for incontinence. So the message is, so if the surgery, if the patient has got no symptoms of incontinence, just for fear of occult incontinence, please don't offer routinely surgery for incontinence. So Is it clear? I'm speaking it again. If there are no symptoms of incontinence, please don't offer any incontinence surgery to a woman who is going for prolapse surgery. Okay, now again, uh, if the surgery has been is going to be done for apical or anterior prolapse, but they don't have any incontinence, so you have to explain them that I just explained they can develop post-operative urinary incontinence. I have explained this before, because once the surgery is done, if there had been any kinking, then kinking will be released, and there could be possibility they may get post-operative urinary continence, and if that appears, then they may require surgery. So this you have to explain this to this woman. But another part, if the patient decides for any treatment that is not available in your hospital, then you will refer this woman to another colleague of yours. Again, now this part is important for the your questions thing. Now, if this patient has come and she has got no preference whether she wants to keep her uterus or whether she does not want to keep her of uterus, okay. In that situation, this could be the options. So options will be vaginal hysterectomy with or without sacrospinous fixation. This is one answer. Second will be vaginal sacrospinous hysteropexy with sutures, or third will be Manchester repair. So if this woman has got no preference of keeping uterus in, then these are the options. I'm repeating it again: vaginal hysterectomy with or without sacrospinous fixation. Number one option. Number two option is vaginal sacrospinous hysteropexy. Hysteropexy, hystero means uterus and paxy means some sort of a repair operation. So in this, what happens, whole of the uterus, they will they will apply some suture on the uterus, and they will hitch it to the this spine, sacrospine. So that means this is in this situation they are conserving uterus. Okay, so all paxies are there conserving it. Okay, so this could be one option. Another option is a Manchester repair. Manchester repair, we know from our UG days. So this is the same Manchester repair can be done, where they do vaginal hysterectomy, anterior and posterior repair, that is Manchester. So these are the three options if no preference for uterine conservation. But now the woman has come, she is looking to preserve her uterus. So in that situation, what will be your answer? Your answer will be vaginal sacrospinous hysteropexy. So hysteropexy can come with suture or Manchester repair unless the woman may have wish to have children. So this will be Manchester repair they are saying, and sacrohysteropexy. Sacrohysteropexy, that means uterus will be like attached to the sacrum. It can be done abdominal approach or laparoscopic approach. So these, though, if they want to preserve their uterus, so answer will be this: vaginal sacrospinous hysteropexy, Manchester repair unless the woman may wish to have children. Okay, and another will be a sacrohysteropexy with mesh. Appears to be slightly difficult to remember, but you have to put it in your head. If there is no preference, then hysterectomy, yes, it will come. So hysterectomy, vaginal hysterectomy with or without repair. Second will be vaginal sacrospinous hysteropexy. Third will be Manchester. Here, as this woman want to preserve her uterus, so these options are the same. Apart from this, they have added sacrohysteropexy. Yeah, this you have to just remember. Then if now the patient has come with the prolapse and she wants, okay, doctor, I just want to have more children. So whatever type of option you are offering, this patient has to be reviewed by regional MDT first. So you may get this question, this as in SPA. This woman has got this degree prolapse. She is looking for having more children, and she wants to preserve her uterus. What will be the next stop? Your answer will be she should be reviewed in MDT before of regional MDT. This will be regional MDT before she go ahead and to have this kind of surgery. So this is important. This is the indication for referral to regional MGT. Now, again, wall prolapse will be slides will be coming, but as this new guideline has come, so now answer from this guideline has become more important rather than GTG prolapse. Okay, so wall prolapse choice will be sacrospinous fixation, vaginal sacrospinous fixation, sacral colpopexy, abdominal or laparoscopic. So this will be two choices. Same choices are given in the wall prolapse guideline also. So sacral colpopexy, if they say it's abdominal and laparoscopic, then in most of the answer it will come abdominal, because in the wall prolapse guideline they say there had been no change if it is done abdominally or laparoscopically. Okay. Now, usually, whenever this sacral colpopexy is done, mesh is used in this. Without mesh, it cannot be done. So, the what type of mesh is used? It is polypropylene mesh. So, from this part, the question may come: what type of mesh? It is polypropylene mesh. Now, about the colpoclysis. So, if the woman has got wall prolapse or uterine prolapse, they don't want to have any vaginal sex, and if they have got any associated comorbidities and where the operation cannot be done, you can offer colpoclysis. Again, this part is very important because I have seen many questions from here. So anatomical success rate will be 98% and satisfaction rate will be 92%. This is again I have taken from TOG. This line is from TOG. Please remember this. Anatomical success 98%, satisfaction rate 92%. Now, since many times you will find a scenario where this patient has anterior prolapse. So your what will be your answer? Usually, previously, we used to put the answer of cystocele repair, but nowadays the answer changes to anterior repair without mesh. So if your choices are cystocele repair, anterior repair without mesh, your answer will be anterior repair without mesh. So please remember this. Your answer for anterior prolapse, it is anterior repair without mesh. So this is the complete answer. Posterior prolapse, posterior repair without mesh. Okay, please I'm putting emphasis on these two words because this will be your answer. Anterior repair without mesh, posterior repair without mesh. Follow up after the surgery, you will get question from here. So whenever this repair has been done, then you have to review this woman, and the review you have to do after 6 months. Okay, so this part will come as a question. 6 months. Now, again, if about this stress incontinence surgery, now you people already know stress incontinence surgery first choice has become Birch colpo suspension. So what they are saying, if concurrent surgery for stress in urinary incontinence and prolapse can be done if this patient has got anterior or apical prolapse and stress incontinence. Now the patient has got two problems, anterior or apical prolapse and stress incontinence. Your answer will be concurrent. That means simultaneous surgery for both problems, SUI and pelvic prolapse. This is important to know. Now, recently, in 2018, this mesh was withdrawn from UK, okay, because of the so many mesh related complication. But recently they have reintroduced it in 2019, and why they have reintroduced it. But they have put a clause that all this patient has to be explained about all complication that can happen with mesh, and also patient has to be, this type of surgery will be done in the tertiary care center if the prolapse is a, if the mesh is required. So this part is important to know. Another part we have discussed in last class also, whenever they are the mesh is used, all details with the manufacturer details and the material detail or whatever type of detail is required, that has to be put in the national registry. And if any complication of the mesh comes, that has to be put in MHRA. No, you may get sometime this type of question in the exam. So just remember all everything about this has to be put in a national registry, and all complication has to be put in MHRA. This is MHRA's Medicinal Health Regulatory Agency. Now, it is very important because previously we need not to read this mesh complications so much, but now because they have new guideline has put so much about mesh, so it is important to know everything about mesh, because in January this guideline has come. So this guideline becomes too much important for you people. So whenever the patient is coming from the mesh surgery has been done and the patient has come to you, so what type of assessment you will be doing? You may get question from here. So you have to do pain and sensory change in back, abdomen, vagina, pelvis, leg and groin. So it is important if there had been any sensory change or if there had been pain, whether it is provoked or whether it is unprovoked. If it is provoked by any movement, if the patient is doing or any this sexual activity, and if it is generalized pain, so what you have to see, whether it is associated to the area of nerve, that is obturator nerve. So you will find question from here. So because most of the time this obturator nerve patient will come with the problem of this that will correspond to the area of obturator nerve. So please remember this. Another part, this part I already told you. So whenever the patient comes, you have to see her 3 compartments. So vaginal compartment will be, why you will see mesh related discharge, bleeding, painful intercourse or dyspareunia, or all this or any trauma. So this part you have, this is the vaginal compartment, or the middle compartment you have symptoms you have to find out. Anterior compartment you will find out because of the mesh if there had been any infection, incontinence, retention or difficulty voiding. So these 3 things, 4 parts you have to find out. Bowel problem, posterior compartment if there had been any pain in defecation, fecal incontinence, rectal bleeding or passage of mucus, and any infection anywhere, and combination of all these symptoms. So this much examination is required for the woman. That is, if there had been a pain in sensory, obturator nerve, vaginal middle compartment, any infection and dyspareunia, anterior compartment urinary problem, posterior compartment bowel problem, and if there had been any infection. So this much detailed history you have to take for the woman if she has come with the mesh complications to you. So you may get any question from here. Now, if the mesh related complication is there, according to the complaint she is doing, you would require referral to the urologist, colorectal surgeon, or urogynecologist. Now, if the patient has come, you will be like after you will be quality of life questionnaire you will be doing, like pelvic floor symptom validated questionnaire is there that will help in assessment and decision making. So sometime you may find this as a question also. So what type of questionnaire you can it would be used? So it will be pelvic floor symptom questionnaire. Apart from this, you will do some examination. So what examination you will do? So vaginal examination to see whether there had been any exposed mass or there had been any pain. Rectal examination to see whether you are able to find mesh, you can see the mesh, or there had been any perforation or any fistula. Neurological assessment, again, why you are doing this? This is done if there had been any motor problem or sensory alteration or the muscle weakness. So this much, so this is the questionnaire and this is the examination. So so if the woman, now this is all about how, so if the woman is coming with a mesh problem, then some of the investigations are done. So these are the new tables. This has been added in this guideline. Though it is difficult to remember and go through it, but some important point I have highlighted. So you may get question where you patient has come with mesh problem, and where you will do examination under anesthesia. Answer, it will be if there had been any vaginal or rectal exposure, that means mesh has been exposed, or if you think that there had been some fistula. So in these two, if these are the two indication where examination under anesthesia will be done. Now coming to the cystourethropy. You already know cystourethropy means something to do with the anterior compartment of bladder. So if the patient has come with urethral perforation, bladder perforation and the fistula, you have to do cystourethropy. So this is easy thing to remember. Now where you will do sigmoidoscopy, you already know this is with the posterior compartment or the bowel problems. If there had been any suspected bowel perforation, you will do sigmoidoscopy. Then where the indication, you will do laparoscopy. So how will you remember? You already know for the pain or chronic pelvic pain, we do laparoscopy. So if any pain is there with the mesh has been put inside, so your investigation you can be done is laparoscopy. Another indication are two, if there had been suspected bowel entrapment, because in sacral colpopexy, what they do, usually the mesh is cut in the Y-shaped manner, and two arms of the Y are applied on the interior and posterior walls of the vault. Then this another part of this, or the longitudinal Y of this mesh, it is then attached to the sacrum. Okay, so this way sacral colpoplexy is done. So anywhere when the mesh has been is taken from put from vault and hissed up to the sacrum, then anywhere this bowel entrapment can happen around the mesh. So or adhesion can also happen. So if three things, if pain, bowel entrapment and adhesion, investigation of choice becomes laparoscopy. Okay. Now, again MRI, where you will do MRI. Now, if the mesh is already inside, you're not able to see anything, but there are signs of infection. So, suspected mesh infection, answer is MRI. If now the fistula you have already diagnosed, you are going to operate her, then you have to know what is the correct anatomical situation of fistula. So for anatomical mapping, you will again offer MRI. Then anatomical, this I explained, if there had been any back pain following abdominal mesh. Okay, because why back pain? Because one part of this mesh is attached to the sacrum. So there could be sometimes this sacroiliitis happens, and in patient will have extreme back pain. So in that situation, you have to, this patient may require MRI, because you have to do the mapping of it. Where is the mesh, and if there has been any problem associated with it. So these are the indications where you have to do MRI. You may get question from here, so you have to know this. I'm repeating it again. If there had been suspecting mesh infection, for anatomical mapping, if you want to do further surgery, if if there had been any back pain, or if you want to go ahead with any kind of surgery after mesh, you need to know the anatomical situation where actually it is that the mesh is lying. So for this you have to do MRI. It is not very much difficult to remember, but just understand, so that will come in your head. So again, this I already explained. So sometimes there could be osteomyelitis, because one part of it is attached to bone. So in that situation, mesh MRI has to be done. Now, in some situation, ultrasound has to be done. This ultrasound can be done transperineal, transvaginal, translabial. It could be 3D. It has to be done by a person who has got experience in interpretation of the mesh complication, because all of the radiologists, those who are doing ultrasound, unless they have special experience in interpretation of mesh complication, they won't be able to diagnose it good. So there are 3 routes of ultrasound: transperineal, transvaginal, translabial on 3D. And usually ultrasound, what they are doing for vaginally placed mesh. Why you will do it? So this part is important. If the patient has come with a voiding function, if there had been suspected infection, if a urethral mesh perforation, and anatomical mapping, if you want to excise it or do surgery vaginally. Okay, so for the anatomical mapping, main important here, you can think of ultrasound scan with voiding dysfunction and not audible. Is it clear now? Is it clear now? Hello, am I audible? Okay. So I was saying ultrasound scan can be done 3 ways: transperineal, transvaginal, translabial, and usually it is done by the person or radio. Can't hear. All Vishnu Priya, you only can't hear. All other people can listen to me. Yes, all other people can hear. Vishnu Priya, you please change your take care of your connection. Yes, all people can hear. Fine. So ultrasound scan is 3 ways. So okay. So it is transperineal, transvaginal, translabial, usually done by the person who has got experience with it. And the answer for that, it will be the patient who has got voiding function, dysfunction after mesh, if there is urethral perforation, or if there had been, you want to do the vaginal excision or like suturing for the mesh. In that situation, you have to do ultrasonography. Now, where you will do CT? CT are 3 things. So anything related to bowel, usually we do CT. Okay, so it will be bowel injury, bowel obstruction, another urinary tract injury. Because we already know that CT, urogram, we do in this ureter injuries. So just remember that way. Bowel thing, we always do CT. So bowel injury, bowel obstruction, and the urinary tract injury. CT has to be advised. Fluoroscopic, not audible. Why your people are not able to see? My internet is going, creating no problem. Still, I'm not audible. Can hear. Some people are saying can hear. Okay, I'm now audible. Fine. So I'll be more near to laptop. Okay, so CT, what I was explaining, the CT usually, friends, we do in our bowel problems, and also we do if there had been ureter problem, like we are expecting ureter injury. For ureter, we always do CT urogram, that you just remember urinary tract injury, and bowel thing is always we do CT, so bowel injury and bowel obstruction. Please remember this well, because you have to understand this also, because if you they will give you 3-4 options, and if you don't know it very clearly, so there will be difficulty in marking again. So this will be the indications for CT. Then thank God for this, they have put only one. If there had been you are suspecting some fistula, so it is not clear if the fistula is there or not. So what you have to do, you have to, in suspicion, you have to put some contrast. If the fistula is there, the contrast will show leakage from there, then you will be able to find out. So if you have got any suspicion, then you have to put some contrast, and all contrast is fluoroscopic studies. Okay, so if there is suspicion for urinary tract injury, fluoroscopic studies will be cystoscopy, and if it is problem with the bowel, we already know anemia, so it will be fluoroscopic contrast studies, that is contrast anemia. This you have to remember or understand very well, and then you will this will be sort of a hot question, I would rather say, where you will do urodynamics and you will do PVR. This part, if I would be examined, I will put this question. So answer will be just 2. Any urinary incontinence and voiding dysfunction. If the patient has got MASH and patient developed these 2 things, incontinence or voiding dysfunction, that would be indication for urodynamics. So remember this well. This you will be able to remember, not an issue. Nerve conduction studies will be if you suspect sub-injury. And what is the commonest nerve? We already know, that is obturator. So this is not very easy table to remember, but keep on just going through this table again and again. So then you will be having an idea. So what is the complication and what investigation is required. Okay, again, any mesh complication has to be reviewed in MDT. Okay, now again, this patient will come and she says, okay, doctor, I want surgery for this mesh, and now I want removal of this mesh because I'm suffering a lot. So you can't do, though this patient will be reviewed first in a MDT, but in MDT also, or the patient has to know what can happen during mesh, or so what you will say. There could be if the mesh removal is done because of that surgery, there could be possibility that her pain may worsen. Any urinary bowel sexual problem can come. Okay, so any pain, her pain may worsen because in sacroiliitis, because of mesh, there is a worsening pain. So if the pain worsens, there could be possibility if you try to remove it, her pain may worsen, or any new complication may happen of all 3 compartments. You have to say there could be possibility if we remove your mesh, your symptoms will completely go. So there could be a possibility that you have done surgery has been done and her symptoms are not relieved even after that. Sometime you have to say there could be a possibility that complete removal is not possible, because when the mesh is put, there is a this fibrinous tissue inside the body. During the healing it gets attached, like it forms over it. So sometimes it is because of all this form adhesion, there could not be possibility that whole of the mesh will be removed. Sometime only part of it will be removed, but if we remove that part of it, there could be possibility her symptom may be improved. And if the mesh has been completely removed and she was happy after the mesh removal, putting mesh for any of her problem like incontinence and prolapse, then if the mesh is removed, her symptom will come back. So this all thing you have to explain to the woman before she can be put her hit again a resurgery for removing of the mesh. So this part is important. Now the mesh complications. You may get this question in your exams. What type of the complication can, so if you will get in a scenario, patient has come and she has put a mesh. Now she has got, so what type, they will give you some scenarios and you have to put the management answer. Now if they say mesh has been eroded but it is less than 1 centimeter, your answer will be what? Topical vaginal cream. And again the second SBA. After estrogen cream, when you will call this woman? After 3 months. So these are two SBA here. Now, if your vaginal portion of mesh is larger than 1 centimeter, then there could be possibility it may not heal with estrogen. This patient may require surgery. Okay, if it is more than 1 centimeter. Second, if the patient has not responded to non-surgical treatment, because first you are giving her estrogen. After estrogen, you are calling her after 3 months. Now you see the mesh is already there. So you have to offer surgical treatment. So these are 2-3 questions that can come from this line. Now again, we have just read if the mesh has been put vaginally and there are some complications. In that situation, you have to offer ultrasonography. Just we read in the table. Let me show it again. So vaginally placed mesh, you have to do ultrasonography. So now some urinary complications can occur because of the mesh. So what you have to say that if we completely remove, if there could be possibility we won't be able to completely remove it, the partial removal will be done, and if the complete removal is done, then also there could be possibility her symptom will come back. And so this part is almost the repeat, and it is same as the vaginal one. Then a complication that can happen with the abdominal placed mesh. These abdominal placed mesh are the sacral colpopexy. So because there could be possibility if this patient wants to go ahead removal of the mesh, because I already told you 2 arms of the mesh will be over the, like it will be put around the wall and one part will go to the sacrum. So whenever you are removing such mesh, there could be possibility of ureter injury or the bowel injury because of the adhesion. And even if the prolapse is removed, even if the mesh is removed, they would require abdominal surgery for that, and also all her symptom will come back, and even after that there could be a possibility you are not able to remove it completely because it will be so messed up inside. Then what you will do if the patient has dyspareunia after mesh? Okay, they say that this patient will, if special assessment indicates a mesh related problem and there is a dyspareunia because of mesh, so this patient has to be reviewed in MDT. So what you will be doing, so you have to find out if there had been any infection. You need to rule out it, otherwise you first of all your answer will be non-surgical treatment. Again it is estrogen if it is atrophy. If it is dyspareunia, there have been no issues, patient can use dilator, or there could be psychosexual counseling or physiotherapy. This part is very much important to remember, because you will get an SB that this patient has got dyspareunia after mesh. What will be your first choice? So your answer will be non-surgical. First of all, you have to rule out infection. Then considering of the non-surgical things, that will be vaginal estrogen, dilator, counseling, and physiotherapy. There may be in question if the patient is not responding to initial treatment, you take advice from regional MDT. So all these things will come in regional MDT, but major surgery thing and mesh related that will go to the tertiary care. Now, what will be, this is the same. If the urinary problems are there after mesh, you have to explain this to this woman. There could be possibility mesh will not be fully removed. There could be possibility of partial removal, and all her problem will come back. And even if after that, if the removal is done, because there could be possibility of fistula because of adhesion. So you have to explain this woman about the urinary tract fistula as well. Bowel problem, nothing more, much specific about it, but this part is important. So if there is bowel complication after a mesh, you have to say this to the woman. So because whenever we are removing this mesh, there could be possibility of bowel injury, and she may land up with permanent stoma, temporary or permanent stoma after mesh removal. You may get SP from this line. Again, in urinary problem, one line is important. There is a risk of urinary tract fistula if the mesh removal or mesh, any surgery for the mesh is after the mesh complication is done. In the bowel complaints, there could be permanent stoma. So now I'm just repeating it few things again, that if the vaginal complication less than 1 centimeter will be estrogen. Follow-up after estrogen will be 3 months, and if the after 3 months she is not okay, surgical treatment. And if the vaginal operation sling exposure is more than 1 centimeter or even larger, you have to consider surgical management first. For abdomen, this is not that important. For dyspareunia, this first line non-surgical treatment will be estrogen dilator and counseling. Not responding, then you have to send this woman to regional MGT. Again, urinary problem, just remember one line. There is an increased chance of urinary tract fistula. And bowel problem, there could be possibility if any repair or any surgery is done for this mesh complication, there could be possibility of temporary and permanent stoma. So this is a sum up of whatever given in the about the prolapse in the new NICE guideline. Till now, if anyone has got any question, can ask me. Any question till now? Any question, or should I move to wall prolapse? Am I audible? Okay. Should I go ahead with the wall prolapse? Okay. Okay. Thank you. So now I missed POPQ classification. Okay, some question will come again, Monis, because I have kept a lot of question. So I'll explain you again. So this is from the guideline. So what incidence of a prolapse or post hysterectomy wall prolapse is, according to the guideline, this is the percentages given: 0.2 to 43. This is there could be one SPF from here, and how much is the, this is again one number. So it is the wall prolapse is more common if the hysterectomy indication of hysterectomy is prolapse. So now if the patient has you have done surgery, a patient for a patient as a prolapse repair, incidence of wall prolapse will be 11%. Okay, and if the hysterectomy has been done for any other condition like benign condition like fibroid, like HMV, then indicate the prolapse incidence, wall prolapse will be 1.8%. These three percentages are important, and this I have put from the prolapse guideline. Now this part is important, though you already know it. This new talk has come in 2019 issue 4, and there had been a very good article about vault complications. So they have written the wall prolapse incidence in that talk. So I found it new, recent, therefore I have put it here. So this question can come, what is the wall prolapse definition? It is if the vaginal vault is below 2.2 centimeter below the TVL from the plane of hymen. So if it is 2 centimeter below the TVL, below the plane, above the plane of hymen, so that will be wall prolapse. Okay. Now incidence as it has been given in the TOG is 36 per 10,000. Okay, now here this is from the guideline. This is from the guideline. Incidence is 0.2% to 43%, and according to the TOG it is 36 per 10,000. I don't know what number you will remember, but this is from guideline and this is from new 2019 issue 4 of TOG. So better to remember both. Now this is again sum up of few points of the guideline. Prevention of wall prolapse, you will find a number of questions from these 3 lines. It is very important. So how you can prevent it? Now you all are being a gynecologist. We are a gynecologist. We are doing hysterectomies daily, very commonly. So what we have to do, Meckel's chondroplasty can be done during VH. If you are doing VH, you can do Meckel's chondroplasty. Now, if you are doing abdominal or you are doing vaginal, you can suture cardinal, that is a McEnroth's ligament, and a uterosacral. Therefore, these are called as suspension. This is 11 ones of support. We just read what are the supports. So you can suture cardinal and uterosacral ligament to the vaginal calf, both hysterectomies, AH or VH. Third, SSF can be done, sacrospinous fixation can be done during vaginal hysterectomy. If the now you have done VH and the wall descent to the introitus during closure, then you can that time only you can do sacrospinous fixation. Okay, so you will find a number of questions from these 3 lines. It is important to remember. And the GTG, they don't recommend any subtotal to as a prevention for wall prolapse. This part is important. Another, what is Meckel's chondroplasty? So this is Meckel's chondroplasty done during vaginal hysterectomy. Meckel's chondroplasty, uterosacral ligaments and uterosacral ligaments are approximated to with the continuous sutures with a continuous sutures, and the POD peritoneum is obliterated. It is as high as possible. Okay, so this is Meckel's chondroplasty. Fine. Now this is again it is very important. So if the wall prolapse has come, management, so it will be conservative stage 1 and 2 prolapse. It will be pelvic floor muscle training. We have just read it should be done for 16 weeks. Okay, this should be done for 16 weeks. And vaginal pessary will come for stage 2 to stage 4 prolapse. So sometime even I myself wonder that if the grade 4 wall prolapse is there, how the pessary can help. But this is MRCOG and we have to follow guideline. So just remember this. For 1 and 2, it is pelvic floor muscle training. For 2 to 4, it is vaginal pessary or vaginal devices. Now, these are conservative things. After it will come the surgical management. So surgical management, what are the indications? So they have done some objective, how it is done. So if there had been vaginal bulge, symptoms of vaginal bulge are there, and POPQ class stage 1 and 0 in apical compartment is acceptable. So it is if the surgery has been done, and like any hysterectomy has been done, and there are vaginal bulge, but if it is more than 1 and 0, if it is the vault is coming up to 0 or up to 1, then it can be acceptable, okay. But above than that, this patient will require any treatment. And now it is very important, you will get a lot of question from this paragraph. What type of operation done to which patient? Usually, it is three type of things are done. One is the sacral colpopexy, second one is the SSF, sacrospinous fixation, third one is your this mesh thing, that is TVM, total vaginal mesh, and fourth is colpoclysis. So these sort of things are done for this wall prolapse. Okay, now what they are saying. So if any patient, she has got multiple compartment prolapse, in that situation, this patient can go ahead with a abdominal surgery. Why? Because extension of the mesh can be done to other compartments also. Okay, so now if your question says multiple compartment, your answer choice of surgery would be abdominal, because you can do treatment for all compartments. Then if the patient this is a very favorite question. So if the patient has got short vaginal length, or if the patient has got dyspareunia, in that situation also your answer will be abdominal approach, because vaginally usually done sacrospinous fixation that causes deviation of the physiological axis of vagina. So in that situation, patient will have dyspareunia. And so if any dyspareunia or short vaginal length problem, if the have come in your scenario, your answer will be this patient will be suitable for abdominal approach. Now, so a number of procedures are there. Sometimes they will ask which one is better. Your answer will be there is no robust evidence to guide a clinician which one is best. So you have to tailor what type of operation you want to offer according to the symptom of the patient. There is nothing like gold standard. Now, if the elderly woman is there, like she has got so many problems and she's not a good candidate for surgery, your answer will go to colpoclysis. So this way you will find your questions, and accordingly you have to answer that which route of surgery will be okay for this woman. Anywhere if I'm not clear, please stop me. Now this line is also, this part of the guideline is full of questions. So if you take up this patient for open abdominal sacrocolpoplexy, or you go for laparoscopic, then in that situation there will be no difference. So the results will be same. One thing, apart from another thing, if you are offering abdominal sacral colpoplexy, then it is slightly better. I put this RDS because it is difficult. It was hard for me to remember. So what are the lower? If you do abdominal sacral colpoplexy, there will be lower rates. Lower rates for RDS. R is recurrent vaginal wall prolapse. D is dyspareunia, and C is post-operative SUI. So this is my mnemonic for abdominal colpoplexy. If you find it useful, you can also, because this is very confusing and the question comes from this slide. Then so the why abdominal sacrocolpoplexy is better? Because lower rate of RDS. Now why vaginal is better? We already know vaginal, or why this SSF sacrospinous fixation is better? Because recovery is early. Abdomen is not open. In all vaginal surgeries, recovery is early. Then again, this part full of this is question. SSF may not be suitable if there has been short vaginal length, and if this patient has pre-existing dyspareunia. So if in your question, this patient, a woman has got dyspareunia or she has got short vaginal length, no to SSF, your answer will go to sacral colpopexy. So therefore, these 3-4 lines are important. Then this part I have explained you. Abdominal sacroplexy, what is done? I said that there is a Y-shaped mesh. 2 arms of the Y will be put around the anterior or posterior wall of vault, and another part will be fixed to the ligament of the sacrum. Okay, so this way it is done. So you can just think in your head inverted Y. Fine. Then so, and if another compartment prolapse is there, so there will be some mesh extension to correct other compartment prolapses also. A question will come from here. So long-term success here will be it is 78 to 100%. Question will come from here. Then mesh erosion, this is favorite question, 2 to 11%. Serious injuries, there could be bowel injury because you pull the mesh around, put it around the vault, then you pull it. During pulling, that bowel injury can happen. Sacral myelitis, because you are putting this to the longitudinal ligament of sacrum. So there is a, I don't know whether you have seen it or not. So there is a tracker is there, that is a sort of a device, and one arm of the mesh, with that tracker, some pin will come, and this will this part of the mesh will be attached to the longitudinal ligament of the sacrum. So you will get question from here only also. Therefore, there is sacromyelitis or osteomyelitis. In this situation, MRI is done, that we have just seen in the table. And now it can come, severe bleeding may happen because there is a one artery that is present here at this place. I don't remember the name of this artery. Therefore, severe bleeding can happen. Your answer will be 2%.
Is it median sacral artery?
Don't remember. I won't be able to give you right. I don't remember. Maybe I will see and update you. So it will be long, just remember this thing. So it will be fixed, it is permanent mesh fixed to the longitudinal ligament of sacrum, and long-term success is 78 to 100%. Erosion is 2 to 11. Serious problem, sacromyelitis, bowel problem, injury and sacromyelitis are the serious complication. Severe bleeding is 2% estimated incidence, but if they give you range, answer will become 0 to 8. Now something about the post-op, this sacrospinous fixation. What usually happens whenever the vaginal surgery is done, we already know from our post-ratio knowledge, there are certain spaces are there. So usually pararectal space is open. And when you open this pararectal space, I have seen this procedure, therefore I'm able to explain you this. So they open this pararectal space, and then they will be able to find out the sacrospinous spine, and then one suture, they will put a series of suture they will apply to vault, and it will be then fixed to the spine. Okay, this way it is done. Usually it is done one side, that is right side, because what the research has shown, it is done 2 times and there will be of no help. So usually it is done one side and it is right side. Okay, so now where lies the question? So now if you are putting this vault to the spine, and spine lies in the posterior part of the pelvis. Okay, so your posterior part will be supported, but there will be lack of support in the anterior compartment of the pelvis or anterior compartment. So there is an incidence of anterior compartment prolapse, and this is the percentage for it, that is 8 to 30%. This part is important. You will get a number of questions. So this is the complication of sacrospinous fixation, anterior compartment prolapse, that is 8 to 30%. Then because the post-operative buttock pain is also very common, that is in 18% of the patient, and it will resolve within 2 to 3 months. Again, important thing can happen because of that area, this pudendal vessels and nerve lies, so there could be possibility of pudendal nerve injury with this. And how you can protect it? If you place suture 1.5 to 2 centimeter medial to the to this ischial spine. Okay, so just there could be an
Dr.
escape from
Dr. Priyata, what will be the anterior compartment prolapse in a case of wall prolapse? It will be mostly cystocele or what?
it will be cystocele.
It will be cystocele, and we can demarcate it like.
Yes.
Okay,
Yes.
okay. Okay.
Very well. And and a sciatic nerve injury can be there, that is in 7.5%. Okay, and there is no evidence that if you put bilateral sutures or permanent sutures, then there will be better success. Okay, so this if with this knowledge will be enough to answer for sacrospinous fixation. Just remember, in sacrospinous fixation and post-operative complication is anterior compartment prolapse. In Birch Colpo suspension, post-operative complication is posterior wall prolapse. Write it down somewhere, because this is a number of questions will come, and we sometimes we get confused. Just remember one thing: there are two opposite type of prolapse can happen as a complication. Sacrospinous fixation, it is anterior wall prolapse as complication, but suspension just reverse it. This way I used to figure it out or remember. Now this Hulls is done, that is a high uterosacral ligament suspension. This they say it is done as a first line management, but it is again under governance and the audit. Why they are so much afraid of this? Because ureteric injury is very common, that is 11%. So you will get one question from Hulls, that is ureter injury 11%. About the colpoclysis, I have explained everything, so I won't be repeating it again. Then this part also I have explained before. So now I'm moving to questions. Till now, theory part is over. So anything, if any one of you have got any question, can ask me. Otherwise, now you have to do exercise of your minds. Any question from theory, or should I go ahead? At least one person should write.
Dr. Priyata, what is Moskowitz procedure?
In Moscovich procedure, there are series of stitches are purse strings, series of purse string stitches are applied, and this POD is obliterated.
Okay.
Should I move to questions, because it's getting late? Anyone, any questions? So I think I should. Okay, so I'm moving to questions now. So this is first question on your screen. So your answer is okay. E. E. You people go for vaginal pastry. Okay, your answer is vaginal pastry. You are right. Good, very good.
Sacrocolpopexy.
Sacral colpopexy. Sweetie has answered D. Insertion of Gellhorn pastry. Yes, sacrocolpopexy is the answer. But why someone has answered me? Why sacrospinous have been answered and why Gellhorn? They are asking, see, they are asking what is the most appropriate. Okay, so this patient, okay, let me explain it again. This patient has 3 months history. This is causing with dyspareunia. Dyspareunia, if the dyspareunia has come in picture, that means this patient is sexually active. So if the patient is sexually active, Gellhorn pastry cannot come. I just showed you a picture. Gellhorn pastry will not work for the sexually active woman. So this option is gone. Then she has dyspareunia. Then your sacrospinous is also already gone. So this is gone and this is gone. Colpoclysis, she has got no medical and surgical history. That means she can bear major surgery. So colpoclysis is also gone. Now left out is supervised. Yeah, sweetie, if the dyspareunia is there, vaginal option will not come. It will be abdominal surgery. I just explained this. Now, if I say supervised pelvic floor, so this patient is, see now, this is hymen will be at this point, okay, and so much of it is out. That means with the exercise won't be of help, and they are looking for most appropriate answer, most appropriate treatment. So this patient, she has got dyspareunia, no vaginal thing. This patient, she is fit for surgery, okay, she is fit for surgery. So most appropriate will be sacral colpopexy. Am I able to make you clear this answer? Though those people who have marked it not wrong, am I clear? Yeah, okay. Yes, good.
AP.
Very good. Now a P belong, small letter belong to wall of the vagina. So answer will be AP. Now it becomes so easy. Small letter for vaginal wall.
D.
Yes, because the POD is not there. Very good. Now this one. Now see, the option has come as shelf pastry. So please remember, Gellhorn and shelf, no sex possible. What is the answer? She is 84 years old. What clicks here?
B.
No estrogen. Not inserting pastry local estrogen cream. Booking another appointment 2 weeks for new pastry, because with the vaginal pastries, ulcerations are common. So if any ulceration is there, patient has to be she has to be given estrogen after 2 weeks. What they're saying, she should be called again. And all these questions are coming from strategy. So what from here can be modified? Therefore, I have
BMI.
very good, excellent. BMI.
Vaginal pessary.
Yeah, it should be the answer. Yes, very right. Because I already told you, anterior compartment prolapse will lead to kinking of urethra. Because of this kinking of the urethra, she is not able to pass urine. So you have to do some correction of that kink. Answer will be vaginal pastry.
Sacral colpopexy.
Yes, very good. Anyone of you, if the answers are not clear, please ask me to explain. Otherwise, I move fast. So this patient has constant watery discharge 2 weeks after anterior vaginal wall prolapse. What do you think she could have, and what you will do to
Ureter.
diagnose?
Bladder or ureter injury. So,
Ureter will not be there. It will be bladder, because anterior vaginal wall repair is there.
okay, bladder injury.
What? A.
Examination under anesthesia, cystoscopy, and methylene glucose.
Usually, cystoscopy is done when you are taking this patient for repair. Before that, you will do something. Next step. This is next step. So you will cystoscopy is operation invasive. Before that, you can do something to diagnose. You have to diagnose first. What you will do for diagnosis?
Intravenous urography.
Good, excellent. So this will be the answer. Now, some people confuse with this high vaginal swab for culture and sensitivity, but this constant means fistula, watery means this thing, urine. So this is constant watery. So they're not confusing you with the infection. Sometimes they will say discharge. They will not add word watery. Then in that situation your answer will become this, but they have made it very clear. Watery discharge constant, that means some problem with the fistula and some problem with the urine. So you will and they're asking about next step and next appropriate step. These are the killers. What is immediate, what is next, what is most appropriate. So please read this very well, because this is the MRI could be an option. You said if you need to track fistula. Fine. If so, when I said MRI, that was if the patient is having patient mesh has been inserted, and after mesh any fistula is there, then MRI will be done. And in this patient, only cystocele repair has been done. So MRI will not come here because mesh is not inside. What you will map? Am I clear, G Anwar? Yeah. Okay. So answer will be this. Now it is good you have put it here. If it is mesh complication, then your answer will change to MRI. So if it is infection, your answer will become high vaginal swab. If it is next appropriate step in this scenario, it will be IVU. And if it is mesh complication, answer will become MRI. This question has been put in the strategy before this guideline came. Okay. Okay, this part I have explained. Now this one.
Now cystoscopy.
Very good. Now why cystoscopy? Because patient is already under patient is already under anesthesia, isn't it? You are already doing surgery. Just do cystoscopy that time. So in this case, now it is not invasive because patient is in theater. Okay. Answer will be cystoscopy. Why? Because if you do cystoscopy, if you find that there had been blood stained urine come from ureter, you can put some stunt there, ureter stunt there, and if you find that some sutures have been passed through bladder, you can cut that sutures. So in this situation, because you are already doing surgery, answer will be cystoscopy.
Sacrospinous. Sacrospinous.
Sacrospinous, no.
Or
She's
centimeter
having
above the hymen, McColl cardoplasty. Sacrospinous is the level of the hymen.
yes. You're
More
right.
than one. Okay.
So it will be Meckel's. It is preventive.
Right.
Okay. As the vault is above the level of hymen. Here it is 1 centimeter above. Here it is above the hymen. So it will be preventive. Meckel.
If it comes up to wall hymen, then we will go for sacrospine.
Okay. Now Yes, your answer, it should be pelvic muscle floor. No, it is not pelvic floor muscles because they are asking for appropriate. If they ask first line, answer will be pelvic floor muscle training. Most appropriate will be anterior repair.
Anterior vaginal wall prolapse. Moderate means more than second degree. So anterior repair.
So please see your question. If it is next step and most appropriate, your answer will change. Scenario is same, but one question changes your answer. So it is A. Am I clear, G Anwar? Okay. Now strategy questions are over. This is from another book.
C.
C.
Very good. C.
Hmm.
So C is vaginal cuff scar or cervix.
Is it B, doctor?
Very good. Because there had been no consensus where interrupted or continuous sutures can be done. Ideally, it can be done both.
B. B. Incompetent.
Very good. It is B.
McCall caldoplasty.
Mecal conductus.
Yes, very good.
No.
Yes, prevention is MEC.
At
Prevention.
vaginal hysterectomy. At vaginal.
Yeah, vaginal hysterectomy, mecal conductus.
Yeah.
70 years old, presented of gynecology, 15 of the points of the not be recorded as part of assessment. D.
Very good, because POD is not there.
Role postmenopausal hormone complaints also.
Posterior vaginal wall prolapse.
G.
Yes, easy question. This does not belong to this class, but I find this question important, therefore I have put it here.
A.
No, it is okay.
Is it E? Is it E?
Yes, it is E. Why it is E? Now tell me why it is E. Because
Square dribbling will be there.
And dyspareunia. This is triad of Urethral diverticulum.
They present with classical triad. But very less patients. Not most of it will not present with it. Classical symptom. Very less number of patients will present with this triad. Okay, no, answer is B. Why? How it can be B?
Why
What
B?
Okay, let me read it again. Okay, they are asking what is true. What is true? They are asking about true. Okay, so this is B is true. Now, why others are not true? This is not 11 o'clock. This is 4 and 8, and it develops in a equal numbers in nullipara. Though traumatic birth is a risk factor, but multi and nulli have got same incidence or of a urethral diverticulum. Even nullipara have urethral diverticulum, and this triad will present in a very less number of patient. Okay, I think it is 1/4 number of patient. I don't remember, but it is less. So this is wrong because it develops in nullipara. This is wrong because most of the patient will not present with this. This is wrong because it is 4 and 8. This is right. B is right, but A. This part we have to see now. A part. So congenital causes may be from remnants of Gartner ducts, abnormal union of primordial fold, and persisting cell rest, especially Mullerian, but rarely found in children. Okay, this is right, but it is not not commonly. It is rarely. Therefore, A is wrong.
Yeah, I got
Okay.
it.
Yeah.
Yeah.
So in A, it is rarely found in children. In C, it is 4 and 8 o'clock. D, it is present in nullipara also. E, it is present in less number, or this triad is present in less number of patient. Therefore, the answer will be C.
Okay.
Clear or not?
Yes.
Now, okay, so this is one EMQ. So just go through this, otherwise I will show you questions. This is easy one. So just read question number 1. 23 years old, para 2, 6 months, BMI 34, cesarean section.
Reduced body mass index.
Lose weight.
Weight.
Very good. Now you people are smart. Weight reduction is first line of treatment. Second question.
Medical treatment. Deep.
Birch-Colpo suspension. Birch-Colpo suspension.
Yes, it will be Birch-Colpo suspension. So old answer was TVT. New answer is Birch-Colpo suspension.
48 year old symptomatic cystoscopy. Appropriate management. Anterior repair.
Asymptomatic.
Asymptomatic.
Do
Nothing.
Due to
nothing.
pelvic floor muscle training.
Nothing.
Pelvic floor
Nothing.
mass.
Asymptomatic prolapse, no treatment.
No treatment. Yes.
Yeah.
Yes.
Just read this. Or I will show it again because it is hard to remember. So just read this first question. What is complication of Birch-Colpo suspension? Okay, it is posterior compartment prolapse. Posterior compartment prolapse. Have you read this question? I'm showing you this.
C.
C. Okay.
Question.
It is D.
Why?
Yeah, I will explain now. So this patient, she
Okay.
has got irritative symptoms. She has occasional stress, incontinence, and also prolapse. Referral is there for bothersome prolapse. Now see her urodynamics. Flow rate is okay. Urgency she has got urgency as 162. So usually it is fine because first the desire come at 150 to 250, but she has a strong urgency at this. So strong urgency usually represents the bladder capacity. It should be at 450 to 600. So this patient has got small capacity bladder. That means she has got urgency. She has got urgency. Fine. So you are dealing the patient of urge incontinence or detrusor overactivity. One thing. Second thing, this patient has complaints of stress incontinence, but you have done urodynamics and no stress incontinence. Okay, and you find a detrusor contraction. Now, what is the issue? This patient has got symptoms of stress, and your urodynamics is showing no stress. Urodynamics is showing urge, and she is referred for prolapse. So she has got some problem. Surgery is offered for different thing, and she has got unstable or urge incontinent bladder. If you do surgery for her, she is going to have a number of problems. So first of all, you have to just make her bladder stable. Therefore, the answer is this. Defer surgery until bladder stable. Prolapse is a reason for referral, but urodynamic shows uh, uncovered bladder problem because she never complained of urgency, but urodynamic said urgency. So this part has to be treated before any surgery is done for this patient. Therefore, the
She
answer
will
is
not get benefit from botulinum toxin.
from
Botulinum toxin injection. She will not get benefit of it.
So why you want to give inject what botulinum toxin you are saying?
Yeah.
But why you can this patient
Actually, she don't have stress. She has urge.
yes, so first line of treatment for urge also will be lifestyle changes and medication. But here the patient is saying something, surgery is for something, and patient has got some problem. Okay, so it is not what patient is saying, you are not getting this. Fine. So first of
Okay.
all, the if okay in your answer will be like treatment for urge incontinence if the patient has if your scenario gives patient has already urge incontinence, but in this question this patient is for prolapse surgery and
Hmm.
occasionally you have found this problem, so you have to treat this problem first
Yeah,
before
yeah.
you do.
Already she had surgery. Okay.
Now
Okay.
am I clear?
Hmm. Hmm.
Okay, read this.
Okay.
So you read this. This is simple question.
Anticholinergic.
Very good. Let me show you the options.
It can be referral to urologist because blood stain urine is coming.
Yes, it can be this because in my opinion this will require cystoscopy Let us see
No.
what is answer.
Yeah, there is no cystoscopy.
Okay, what they are saying.
No, it is 17.
So this patient has multiple. This patient has got.
Both stress and urge, but there is
Okay.
blood-stained void residue.
Yeah, now this
She's
patient is a
in
complex. This patient is a complex patient. Symptom of mixed, and she's showing
cystitis.
blood stain. Now you are right. You have to refer her to urologist. But if the MDT has been given, then that will become the better answer, because this patient has complex problems. So this require referral to tertiary will not come. This is not a tertiary problem. Referral to urologist can also be an option, but there is a tie in between E and K. So what do you think? Which is better, E or K? Single person or meeting?
E will be
Much
better.
will
Yeah.
be good.
So if this option is not there, MDT, your answer will become K.
Referral to urologist, yes.
Yes. So with a single thing, answer changes.
Yes.
Okay. So this patient, there had been a surgery, and after surgery, she has got urodynamics. But she has after contraction, after avoiding contraction. But I have already showed you answer. This after contractions are bladder observed during voiding cystometry if this patient has surgery before. So patient will require counseling against the after effect of surgery. So this is post-op complication after contraction of bladder following surgery. This part we have done. Okay, we have done this. Okay, now this is SP again.
And then she is not currently taking medication for stage 1. But prolapse. Pelvic floor training.
Very good.
D.
Yeah, pelvic floor training.
Here the distance, the restricted location compartments and constant rotation and shift equivalent to reduce the chance of the posterior
Macrospinous fixation. No, Meckel's coltoplasty.
Mechanical cultoplasty.
Yes, Meckel's
E.
coltoplasty.
72 years. Manipulated in the profit type in the examination sheets, right? Procedure. A.
Yes, A. Good.
Which of the following is the pelvic organ? Heavy lifting.
E.
A previous vaginal delivery.
C.
E, I think.
Heavy lifting at the C.
Heavy lifting. In vaginal delivery, it is a risk factor, but usually it occurs in multipara. So if it is a one delivery, then it will be like very less chances. I think therefore the answer becomes heavy lifting. Okay, they are saying 2 or
2
more
children
children.
or more. But heavy lifting, is that so much effective to lead to prolapse? Solo?
Yeah. Because there will be a heavy weight lifting, there will be constant pressure on vaginal floor, pelvic floor.
Okay.
Molecules was 1738 suggest pregnancy with number December 40
B.
D. D.
But the answer will be D. Because it is not clear. It is better answer. That means some research work has already been done. This is just a statement. I can say, okay, cesarean section does not prevent a prolapse. Some other person is coming. So see, we have done many studies and it shows it is unclear. So this carries more validity than this line. So answer will be D. That means some studies has been done. Okay. So now it is over. All the classes, all things are over. If anyone has got any question, can ask me.
Can we get that record? Because I could
Yeah,
not attend
please
the first.
record of this session.
I
Yes,
just attended.
yeah, I'll be posting this recording once it is ready.
Thank you.
Thanks for your effort.
Okay, thank you.